So we move on to the next presentation, patient preference for hydroxychloroquine in systemic lupus, preliminary analyses. The paper is by Jennifer Dollinger, Celline, Brasil. Glenn Hazelwood, Ryan Dollinger, Jennifer Lee, and Sasha Bernat, Marcus Wong, and Sasha Bernatsky. And the paper will be presented by Dr. Celline Almeida, Brazil. Celline, bienvenue à la conférence laurentienne de rhumato.
Merci, bonjour, good morning. So my name is Celline. I'm going to present today on behalf of Jennifer Dollinger, who is the author of this project. And we can go to the next. Oh, sorry, I forgot to present myself. I'm a postdoctoral fellow at the Research Institute of the McGill University Healthcare Center. And I have no conflict of interest to disclose, and this project was funded by CLR. So as you may know, systemic lupus is a lifelong autoimmune disease that can affect any organ, and that usually will not stay in remission without drugs. And lack of control will lead to damage of organs, and severe lupus can lead to fulminant inflammation and death. The cornerstone treatment we have for lupus is hydroxychloroquine, which is used by every single rheumatologist in North America and greatly reduces lupus flare. But if you get lupus at the age of 18, you could need drugs for 7 years or more. And long-term use is associated with adverse events such as retinal toxicity, which is a serious and irreversible condition that may evolve to vision loss. Next. And patients and physicians struggle with the decision of whether to reduce or discontinue hydroxychloroquine to avoid toxicities or to maintain therapy to avoid lupus flares. And understanding patient preferences for the trade-offs involved in this decision can help inform patient-centered treatment approaches. Next slide. So our objective was to explore patient preferences for hydroxychloroquine therapy and the reasons behind these preferences. The patients in our study were part of two systemic lupus cohorts in Canada, the McGill University Health Center Lupus Clinic and in Quebec, and the Southern Alberta Registry for Lupus Erythematosus. And participants were recruited during clinical appointments between March and July 2020 using convenience sampling. And the inclusion criteria included adult lupus patients currently or previously on hydroxychloroquine. They were fluent in either English or French and who were able to provide informed consent. And the interviewer conducted phone interviews using a standardized questionnaire. And the main questions guiding the interview included asking patients about their past experiences in changing hydroxychloroquine. And then what are the preferences and the factors affecting these preferences. And the interview recordings were transcribed, and the French transcripts were translated to English. And two reviewers independently conducted the thematic analysis by individually generating codes and mutually ruling out the discrepancies between them. So we completed a total of 42 interviews, and none of the patients who were approached refused to participate. The majority of subjects were female and Caucasian, and the average age was 56 years, and average lupus duration was 23 years. And the three initial themes we identified were they focused on the experiences changing hydroxychloroquine dose, who makes a decision, and the reasons behind the decisions. So this theme relates to whether a patient experienced hydroxychloroquine dose change or cessation. And we observed that over a quarter never modified the dose since they started taking hydroxychloroquine, with some of the patients saying they never actually thought about this option. So 42 have already lowered the dose, 26% temporarily stopped, and 14% permanently stopped hydroxychloroquine. And these numbers won't sum up to 100% because a patient could have already lowered the dose and stopped at some point at some point in time. Next. So the majority of these decisions were made by the doctor, and some mentioned that the decision was made after a discussion with the doctor. So for example, this patient on the left, my doctor and I had a discussion a couple of years ago when I was on 400 milligrams and we lowered it to 200 milligrams. However, almost a quarter of patients made a decision on their own without communicating it with the doctor. So for example, one say, I wondered if the day I take 2 pills is even usable. I decided to take 1 pill every day. And the decision to stop was made on my own, and I didn't warn the doctor until 2 years later. Next. And the reasons behind patients' decisions regarding lowering the dose or discontinuing hydroxychloroquine were mainly related to concerns with side effects, as exemplified by this patient on the right. I am a little concerned about heart and vision issues long term. And the reasons for maintaining The reasons for maintaining hydroxychloroquine included fear of jeopardizing lupus control, such as anytime I get my medication change, I usually get flare-ups. And on hydroxychloroquine, I think my symptoms are lessened, my major problems are less frequent and well controlled. And the management of multiple medications was also mentioned. For example, I'm trying to lower the dose of prednisone, and other medications such as hydroxychloroquine allow me to have my lupus under control. And finally, trust under physician was also came up as a reason. So for example, I have been staying on hydroxychloroquine mainly because I have great trust and a great relationship with my doctor, who is very intelligent and very up to date. Next slide. So our preliminary analysis of the interviews revealed patients' experience in changing or not their hydroxychloroquine treatment. And in summary, around 40% have stopped at some point or permanently. And most decisions were made by their physicians. And we identified several factors influencing decisions to maintain hydroxychloroquine versus to decreasing the dose or stopping. And for example, regarding maintaining, the reasons were to reduce prednisone, to control lupus, and lack of knowledge of other alternatives. And the main reasons for reducing or stopping was to avoid toxicities, forgetfulness, or suspicions about hydroxychloroquine effectiveness. And in both scenarios, trust in the providers had a major impact. So for some patients, if the doctor says we should lower this dose or we should maintain your treatment, they would do it without much questioning. Next. So as limitations, we point out that patient preference is sometimes hard to define, measure, and interpret. And more importantly, it may vary with time and circumstances. And for example, the risk of perception is higher when the patient is not feeling well. So a patient who just had a severe flare may prefer to keep their treatment as it is and don't want to lower or stop it. And also our results may be biased towards preference of more experienced patients, because although we included patients with 2 years of diagnosis, the mean and median were over 20 years, and then they impact it, the preferences may be different. We also observed that sometimes the patient's current dose didn't match the preference, and the possible explanations include that the fact that the patients didn't communicate. One of the possible explanations would include the fact that the patients didn't communicate the preference to the doctor. Maybe they're not sure of consequences of their decision. So patients were keen on leaving the decision up to the doctor. And this is a really important point, because patients themselves may not be 100% in touch with this concept of preferences. They are not used to making decisions, and physicians are not used to having their patients expressing their preferences. So the providers need to be aware of the influence on patients' decisions. And we believe the first step is the recognition by patients and providers that a significant decision is to be made, and that the process should include both sides discussing options and outcomes. So our conclusion, if you know what matters most to patients, we can develop tools to help communicate this in a shared decision-making context. And our final results will inform discrete choice experiments to help further develop a personalized approach to hydroxychloroquine treatment in SLE. I want to acknowledge our funding sources. So again, this project was funded by CHR. The lead author, Jennifer Dollinger, received a McGill Summer Student Bursary. And we also received support from the Single Family Fund of Lupus Research. Thank you so much for listening, and I'll be glad to take any questions.
Thank you very much, Celline, for giving a very lovely presentation of a very pertinent topic at all times, and with the specific example of hydroxychloroquine this year, particularly topical. But I think I noticed that indeed the study was conducted in the spring of and summer of 2020. Mm-hmm. So what was the impact of Dr. Arruda's prescription to stop everyone's Plaquenil in the spring of 2020? Or did you just wait for things to settle?
Yeah, we waited. We planned this study a long ago, and our plan was to conduct personal interviews, do focus groups, but we didn't want to delay, so we did phone interviews, but we didn't enter specifically in the question regarding COVID, because our group did another study, qualitative study, asking how was the impact of this decision. But we know that many patients were really afraid of running out of medications. And we also did another study who identified some patients who were on major risk of developing flares if they are without the medication. So we also send out this information for providers and say, take care, don't stop hydroxychloroquine and these subgroups of patients because they're in major risk.
So lots of data to look forward to hearing in the near future. Are you considering looking at hydroxychloroquine blood levels at some point and also integrate that into the decision-making process?
Yeah, that is a great question. And every presentation we do, people ask about that. We currently don't have. It's not part of the clinic routine to collect. But yeah, Dr. Sasha Bernatsky is looking for ways so we can explore there in our future analysis.
Well, that's terrific. Thank you again, Celline, and best of luck. And also regards to and thanks to Jennifer. Take care.
Thank you.